Hello everyone, and welcome to the Henry Schein webinar series on COVID-19 on YouTube. I'm Dr. Gary Severance with Henry Schein, and it is my pleasure to welcome you now to this monthly series, where we hear from Dr. David Reznik, Chief of Dental Medicine for the Grady Health System in Atlanta, Georgia. In this episode, Dr. Reznik will share and address vaccine information for children and adolescents, CDC guideline updates, including mask protocols, and findings from a recent aerosol study. We'll turn it over to you, Dr. Reznik, and from all of us, we want to wish you a very happy, belated birthday.
Well, thank you, Dr. Severance, for the birthday wishes, and from everyone at Henry Schein. It has been quite the year plus for us. We started this on March 23rd. Where things really looked quite desperate at the time, into a situation now where we're learning to live with COVID as more people get vaccinated, masking requirements change. But we're also going to focus on a few things today that aren't changing. And it's important that we focus on how we can provide the safest dental visit and continue that effort. So we had some objectives today. I thought I would sort of help you see where my brain is at the time. So we'll go over where the current progress is on vaccination efforts within the United States. We will have a discussion on the new CDC masking guidelines for the general public, and do they impact our practices and how that might work. The overview of some conditions where vaccination might not be as effective as it is for people that are healthy. And I think we need to realize that there's still very vulnerable people in our society that could, even with vaccination, get COVID. They might not end up in the hospital, they might not die, but they could get sick and it could exacerbate their pre-existing conditions. I'll briefly cover the CDC recommendations for the approval of Pfizer-BioNTech's COVID-19 vaccine for adolescents. I think that's important. And then I'm going to do a thorough review of a recent publication from the Journal of Dental Research, Sources of SARS-CoV-2 and Other Microorganisms in Dental Aerosols. If you're on any of the dental listservs, if you're on any things that come from the American Academy of General Dentistry or the ADA or several sources, you have all received a blurb about this. And I really wanted to go into a bit more detail to explain maybe some of the limitations in the study and some of the things they found, and then also why we need to continue doing what we're doing. And that's the final thing. Are there any real changes to what we're doing as far as infection control now that a significant portion of the population has been vaccinated? So with all that said, let's get started. There are more than 157 million American adults, or about 60% of the U.S. adults, have had at least one dose of COVID-19 vaccine, according to data that came out of the Center for Disease Control. Approximately 123 million American adults, or 47.1% of adults in the U.S., are fully vaccinated. So that's about 37% of the entire population in the United States is vaccinated. So it's a little bit more than a third, but it is not half the population. It's not 60% of the population, and by no means is it 70%. We can look at the graph on how we've done with getting vaccination efforts, and we can see that there was a good uptake in March and in April, and we were doing really well. It sort of has leveled off, and I think part of that has to do with those that truly wanted to get vaccinated were those cars that were standing in line, or people standing in line and going to these mass vaccination sites, or were getting primary care. Now we have folks that are a little bit more hesitant for one reason or another, and it's how do we get the messages that vaccines work and don't cause damage or cause any harm to those that are still sort of sitting on the sidelines. So we still have a ways to go, and we still have the very new effort to actually vaccinate our adolescents. So that's also important. So again, if you look as of May 17th, almost 124 million people, or 37% of the population, was fully vaccinated. So we have a ways to go. If we look at gender and gender differences according to CDC information, and they have this gender information on about 90% of people who have at least one dose and 91% who are fully vaccinated. So that would mean they've had both doses and then hopefully waited that 2-week period of time post your second dose if you've had Moderna or Pfizer. And this does not include the J&J data. So males received 71.5 million, or 44% of one dose. Fully vaccinated, it's at 32% compared to females who received one dose at almost 81 million, almost 10 million more people, and at 48.5% have had one dose, and fully vaccinated, almost 61 million people, or 36%. So our female population is doing better about taking care. We really need to encourage our males out there to get vaccinated. So follow the lead of our female population. They're doing better than we are, and it's not a competition, but the faster we all get vaccinated, the faster we're all in a safe environment. So that's why I wanted to bring this data in front of you. And then if we look by age, we also see remarkable differences based on an age stratification. Again, if you look at the color chart here, the reddish, pinkish color had at least one dose, and the blue color is fully vaccinated or 2 doses. So if you look at the first target population, which were 65 or older, you can see that from 65 to 74, about 84% had at least one dose. And fully vaccinated is close to 70%. So those are really strong, great numbers. We've done a great job with those that are more vulnerable. If you look at the next population on the chart, it's 75 and older, and even there, we really have done a great job. So we knew it was impacting people that were 65 and older, and after this latest birthday, I'm getting closer to that day. And so we knew that we had to get those folks and healthcare workers and frontline workers vaccinated. So we did an excellent job, I think, with vaccinating our older and more at-risk population. But there's a significant drop-off if you look at ages 50 to 64, which I'm still in that age group. And you can see that we have a lot of work to do there. And as you go down the list, you can see that it continues to fall off. And that's because we associated hospitalization and death at the beginning of this epidemic with those that were 65 and older or who were medically compromised. If you look at one of our youngest groups, those that are 18 to 29, about 39% have received one dose, and about 25% have received both doses. So that group is also very vulnerable, and we need to look at that. If we want to get control of this pandemic, we need to get as many people as possible vaccinated. So one of our jobs as trusted healthcare professionals who see our patients on a regular basis, who have the ear of those that we serve, is to help them make the decision. It's not a judgmental thing. It's here is the data, here is the potential side effects. They last a day or two, and now you are protected. And according to the latest masking guidelines, if you've had your second dose, if you're using one of the mRNA vaccines, and it's been 2 weeks past, you can be outside without a mask. You can go into larger areas without a mask. You can go into restaurants without a mask. So there is some level of trying to appease people or get people to get vaccinated so they can go back to a more normal style of life. The next chart I want to show you, and I'll spend some time on, is where this is according to your state. Now, I understand that the bigger cities might have more concentrated people who have been vaccinated. And when you compare that to more rural areas, we already know that rural areas are one of the biggest places or voids that we have in getting people vaccinated. We also know in some traditionally underserved communities, we're having a harder time getting people vaccinated. So we really need to expand our focus not just on big cities like Atlanta and New York and San Francisco, but also look at our rural areas. I have a wonderful residency program in Albany, Georgia, and they've done an excellent job down there. of vaccinating the residents in those counties. So there's really some great programs that are out there at federally qualified health centers that we really need to look at. So if you look at the chart and you look at the map, I always start with my state because I think that's important to take ownership. And only 29% of the people in the state of Georgia have received both vaccines. 37% have had at least one shot. And then you look at our neighboring states in the South, and you can see that there's a trend. The number for both vaccinated shots in Alabama goes down. In Mississippi, it goes down. A little bit of an increase in Louisiana to 29%. Oklahoma at 32, Texas at 32, and Florida, if you look at the southern states that are southern contiguous states, is actually doing pretty good at 35%. That's because there's a significant older population in Florida, and efforts were made to target those folks very early on. Hawaii is doing an extraordinarily good job with 44% having both vaccines. Let's look at other places around the country. I have talked about Wyoming on several times because a dear friend of mine, Anna Kinder, runs the Casper Department of Health, which just won an award in Casper. And they've actually done a very good job of having about 30% getting vaccinated in a very, very frontier state. So it's not just rural, it's frontier. New York, 42% have had both vaccines, extraordinarily well done. Vermont, 47. So you can look at your state and see that nobody is at 50% of vaccination rates. So we still have work to do throughout the United States. Even when you get close, like in Maine, where 48% have had both of their vaccinated shots, they're doing great. They're an example. So is Connecticut. So is Rhode Island, so is Massachusetts, but we have to do this nationwide. We are people that like to travel. It's summertime, and we're going to be going from maybe very hot areas to different parts of the country or going on vacations. So we really need to still stay safe, and I think that's important. And this gives you an idea of where you are in the country and where your state levels are. So let's talk about this new general guidance on mask use, which has caused a significant amount of confusion. There is no doubt. We went from one day of having to wear a mask all the time to another day where we don't need to wear masks in certain areas. So fully vaccinated people don't need to wear a mask or physically distance when outdoors or indoors in large or small gatherings according to the new CDC guidelines, which are sort of changing a little bit. Fully vaccinated should continue to wear a mask while traveling by plane, bus, or train. That's very important. And the guidance does not apply to certain locations such as hospitals, nursing homes, dental offices. Dental offices, that is very important, and prisons. So when your patients come in, we're not changing how we do our business yet. The CDC has not changed their guidelines yet. The ADA is coming back and saying we haven't changed our guidelines yet, so we really need to continue to do temperature checks. We need to make sure that we have some physical distancing in our waiting rooms and masking, because our waiting rooms, for the most part, are not enormous areas, and we might have several people in there. Unvaccinated people do remain at risk and should continue to wear masks and get vaccinated as soon as possible. People who are immunocompromised should speak to their physicians to determine whether or not to keep masking. And I will go into this briefly. Does the CDC guidance overrule local mask mandates? And the simple answer is no. If your state or your city still has a mandate in place, then you have to follow that mandate. So throughout this pandemic, states and cities and businesses have often set up their own mandates. It's not a federal rule, unlike mask wearing or occupancy rates. So you'll find one major chain of a grocery store, I think the largest in the country, is maintaining its masking procedures. And one of the largest wholesale retailers is saying you don't need to wear a mask. So even from our businesses that we frequent on a relatively frequent basis, we are seeing differences in the interpretation and how it works. Up until the new CDC guidance was released, we had 26 states and the District of Columbia that had statewide or district-wide mask mandates still in place, according to research from the Kaiser Family Foundation. But after that updated guidance came out, almost all of those states were changing. They're changing their mandates. We have never had a mandate in the state of Georgia. We looked upon people to take care of each other, and until this mandate came out, we were doing fine. Until this new CDC guidance came out, we were doing really well, I thought. So, fully vaccinated, what do the new CDC guidelines mean? Well, the reality is, for at least in the near term, you're most likely going to end up needing to carry a mask with you. For instance, I went out for my birthday to dinner. I had a mask in my pocket, and I actually put it on when I walked into the restaurant, and I kept it on until I was seated. However, other people walked into the restaurant without masks. There was no guidance saying that you had to do A, B, or C. There was hand sanitizer present at the desk, at the reception desk for this very nice restaurant. As I mentioned before, some states and cities still will have mandates in place. That's a local decision making. And then some businesses, restaurants, and retailers may also continue to require face masks if you want to be served in those places. And one of the issues is it's sort of hard to tell who's been vaccinated and who's not been vaccinated. Can you tell? Well, we don't have any federal mandate to have some kind of single vaccination credential. You can't look at somebody and tell that they've been vaccinated. And regretfully, one of the biggest issues that we have, and these aren't even anecdotal reports, people are making fake vaccine cards. And according to what I've learned on some social media, it's very easy to make these fake vaccine cards. All you need to do is have a printer and the right kind of paper in place. And so, how do we actually know if someone is vaccinated or not? The answer is we don't. So, in dentistry, after HIV hit, we assumed that everybody who walked into our office had a bloodborne pathogen. That's why we started wearing gloves. That's why we started having face shields. That's why we started doing all of the present bloodborne pathogen guidelines. That was a reason for those to be in place. We didn't know who had HIV or hepatitis A, B, or C, but we treated everybody as if they had a bloodborne pathogen for the safety of the providers, the other patients that would come in, and of course, our staff. With COVID, can we tell? Actually, we really can't tell if someone has an aerosol generating something that could be transmitted by air. We really can't tell. So we still need to keep in place all of the extra precautions that we have, such as wearing N95 masks when using aerosol generating procedures, as well wearing face coverings or shields or goggles. The glasses I have on today are not considered safety. So things could get into my eye. And if you follow Joint Commission rules, the eye wash is not a pleasant thing. It's a 15-minute thing. So the whole goal is take care of ourselves. Even if we're all vaccinated, we still need to take care of ourselves. So coronavirus vaccines also might not work in some people, and they might be people that we love or family members or those that are very special to us. There are millions of immunocompromised people living in our country, about 3 to 4% of our population for whom the shots may not work fully or only partially, and you won't get as much protection as you normally would. Emerging research shows that 15 to 80% of those with certain conditions like blood cancers or organ transplants are generating very few antibodies, so they might not be as safe as others. Vaccine makers excluded a lot of immunocompromised people from their clinical trials in an understandable rush to get this approved for the main general population, and that makes sense. Were there people, say with HIV, my field, included in these trials? The answer is yes. So we have some data, we sort of have an idea, but then again, and I'll talk about that specifically in a few slides, but we have a certain percentage, 3 to 4% of our population, that is still at risk because we don't know that the vaccines will work. Between the CDC and the White House, they highlighted challenges for such patients and the vaccine in recent news briefings, which they acknowledged that the first documented case of the so-called New York variant, and we try to stay away from location calling them variants, but the B1526 was found in a person with stage 3 HIV who had been completely vaccinated. So this is just a case. We know there are other cases out there. So early data suggests that vaccines offer some protection, although maybe to a lesser degree than you would see in someone who is healthy, for most patients with HIV and autoimmune conditions, and even rheumatoid arthritis. So at the University of California at San Francisco, a highly respected medical school and research center, Dr. Gandhi and her colleagues found that HIV patients seemed to produce fewer antibodies on average. But she's optimistic that the amount was sufficient to protect most people, so we really aren't taking special precautions with my patient population. She said one recent study showed that another arm of the immune system, or T cells, or the white blood cells that fight off infection, appeared to respond to the vaccine similarly in both HIV patients as well as those without the disease. So these are T cells. Now, in our patients who have advanced HIV, they might have a small number of T cells, and so the advice to those people might be a little bit different than those who have a really high T cell count. So the antibody response might be blunted, but the T cell response is not, and so we might be okay. And so again, they need to talk to primary care about where masking is important or not. A hematologist at the University of Pittsburgh Medical Center and the lead author of a study on blood cancers and vaccines posted a study before peer review, and we've been talking a lot about these pre-peer review studies that have been out there, how crushed he felt when he saw low antibody results for nearly half of the 67 patients his group tracked. So this was somebody who was looking blood cancers and vaccines. Patients on treatments that impact B cell function appeared to have the weakest results. That made sense to him because B cells help produce antibodies, another part of our immune system. As for transplant patients, early data is also concerning. A May 5th study published in the Journal of the American Medical Association found that 46% of almost 660 transplant patients did not mount an antibody response after 2 doses of either of the mRNA vaccines. So that is concerning. Although the study demonstrates an improvement in antibody responses in transplant recipients after the second dose, these data suggest that a substantial portion of transplant recipients likely remain at risk for COVID-19 even after the second dose. So if you have family members that are transplant recipients, I'm sure you're doing everything, and they're doing everything possible to stay safe. The lack of reaction is probably a result of the immunosuppressive medications that they're on to maintain the transplant. In St. Louis, Washington University, Alfred Kim said that although the majority of his patients with autoimmune conditions who were studied are mounting a healthy antibody response, about 15% had very blunted or undetectable antibody responses. So these participants had a wide range of illnesses, everything from IBS or inflammatory bowel disease or systemic lupus or rheumatoid arthritis. So again, they might have the second dose and they might have waited 2 weeks, but are they going to be as protected as someone who does not have an autoimmune disease? And the answer is, for 15%, not as well. So again, we need to take some precautions. Changing now a little bit to where we are with getting the next population, our adolescents, vaccinated. So when they go back to school, they could be safe. And on May 12th, 2021, the CDC recommended approval of Pfizer-BioNTech's mRNA vaccine for use in adolescents. This followed the announcement on Monday, the 10th, that the FDA had authorized the Pfizer vaccine in this age group. And they recommend that everyone 12 years or older should get vaccination, and that will increase the percentage of the total population that is vaccinated. Although fewer children have been infected with COVID-19 compared to adults, children can, 1, be infected with the virus that causes COVID-19 or SARS-CoV-2, get sick from COVID-19, and I know no one wants their child to be ill, and they could spread COVID-19 to others. So we want people back in school. We want people back doing athletics. We want all the things that people my age were able to do when we were in our adolescent years, and parents today, because I'm at grandparent age, we really want to get them back to a normal set of circumstances, so vaccination will definitely be helpful. So, the blurb that so many people have heard about, microbes and aerosols mostly, and I underline that word, come from dental irrigant, not saliva. And I'm going to basically go over what the blurb says here. Researchers at the Ohio State University College of Dentistry and Extraordinary School say they have tracked the origins of microbiota and aerosols generated during treatment, including ultrasonic scaling, implant osteotomy, and restorative procedures, proving the risk of transmitting SARS-CoV-2 during these treatments is low. The researchers collected samples of saliva and irrigant from 28 patients undergoing these procedures before each procedure began and then 30 minutes post the procedure. Then they collected condensate, which is a nice way of saying splatter, from the face shields of the operator, the assistant, as well as the patient's bib, and from an area 6 feet distant from the operation site. This study showed that it's possible to trace the source of contamination through DNA microbiome analysis. Now, the major source of microbes and aerosols came from dental irrigant. So the first thing, I've been wearing a shield, a face shield, since I started at the Grady Health System, which was, 28 or so years ago. I was amazed at the amount of splatter and blood that showed up on my face shield with the extraordinary dental assistants I still work with today. And so the fact that they were getting splatter on face shields to me means we still need extraoral evacuation. As good as the assistants were here, as good as what we do, we don't really want splatter. If you're wearing goggles or you're wearing the N95s, we really don't want splatter hitting at our faces. So that's why I'm a big proponent of face shields as opposed to goggles. Goggles are fine if you're doing an exam. So I think that there's some issues that we need to go through. This is a great study. It's a peer-reviewed study. It's published in one of the best journals that we have. But there are some areas I think we need to clarify as opposed to just looking at the headline. Headlines are important. They help inform, but we really need to look into a little bit more of the data. So the researchers tracked the origins of the microbiota and aerosols generated during ultrasonic scaling, as I mentioned, implant procedures and restorative procedures. They did reverse PCR sequencing to identify and quantify SARS-CoV-2 and in source tracking. They revealed significant class separation between the salivary microbiome and aerosol microbiota deposited on the operator, the patient, the assistant, and the environment. Researchers discovered that 78% of the microbiota in condensate, or the splatter, could be traced to the dental irrigant, which makes sense. That's where most of it comes, while saliva contributed to a median of 0% of aerosol microbiota. They also looked at low copy numbers of SARS-CoV-2 virus in the saliva of several asymptomatic patients, but none in the aerosol generated from these patients. And I'm actually going to go into some detail about that, of maybe why they didn't see some. Together, the bacterial and viral data, and this literally comes from the publication itself, encourage us to conclude that when infection control measures are used, and when I talk about infection control measures, I'm talking about what was put into place from the CDC guidelines and from the ADA guidelines of wearing N95s, wearing face shields, wearing disposable gowns, etc., etc. And also including using preoperative mouth rinses in this study, and they had intraoral high volume evacuation. Dental treatment was not a factor for the risk of transmission for SARS-CoV-2 in asymptomatic patients, and that standard infection control practices are sufficiently capable of protecting personnel and patients from exposure. So again, I want to talk about the fact that they were getting condensate, and these people had low viral load, and we'll cover that in a minute, and they found condensate on shields, on the patient bib, and in around the area. Participant selection and recruitment. So who was in this study? It was 28 people, so it's a pilot study seeking dentistry between May 4 and July 10, 2020. Exclusion criteria were being less than 18, current pregnancy, requirement for antibiotics prior to dental therapy, which we don't do very often anymore, self-reported HIV or COVID-19 history, COVID-19-like symptoms since January 2020, and any antibiotic therapy within 3 months of collection. Very good set of exclusion criteria. Operating conditions. The aerosol generating dental procedures, as I've mentioned before, were those implants, restorative, and high-speed scaling, and I think that's important. It was delivered by 5 operators, and assistants. So when the scaling was done, not only did they have high-volume evacuation, but they had dental assistants. They had 2 enclosed operatories, gives you the measurements there. And I think that this is a bit of a misprint because the exchange rate of 6 per minute would mean that you were outside, basically. But it's probably 6 per hour, which is what a hospital would go by. Since aerosols are generating during normal physiologic activity, such as coughing, speaking, singing, screaming, the operator assistant, and sample collector wore N95 masks. Hint number 1, we need to continue to wear our N95 mask as recommended by the CDC and the ADA. And the reason was that it was during the entire period, it was to reduce microorganisms in extraneous sources. High volume intraoral evacuators were used for all aerosol generating dental procedures. 23 individuals had a pre-procedural rinse of 1% hydrogen peroxide, which is what we do in our program, and 5 underwent scaling, did not have that pre-procedural rinse. I don't know the actual logic for that because we actually have pre-procedural rinse on all of our patients that we see here, even our removable prosthodontic patients. Sample collection prior to the procedure, 1 ml of unstimulated saliva and irrigant from the demplant or implant unit were collected in tubes. At 30 minutes following the procedure, condensate was collected from the face shields, I'm going to make that point again, of the operator and assistant, the patient's chest, in an area 6 feet distance from the operator or the environment. Source tracking analysis revealed that irrespective of the aerosol generating dental procedure, the microbiota from irrigants contributed to a median of 78% in condensate, and there you see the range, while saliva contributed to a median of 0, the range from 0 to 82. So in some cases, there was a lot of saliva, and most of the cases, it was very minimal. On average, 20% of the microbiota could not be attributed to either source. Salivary bacteria were detectable in condensate in only 8 participants out of the 28. Of these, 5 had not used the pre-procedural rinse. Again, that's why we use this pre-procedural rinse on all of our patients. In the 8 cases, the patient's chest was the most frequent site of deposition. So again, we have to make sure that we have the patient environment safe and our staff environment safe. The research team then investigated if aerosol dispersion of SARS-CoV-2 followed the same pattern, and it was identified in saliva of 19 participants with a viral load between 27 copies and 912 copies, and I'm going to revisit that in a moment. The virus was undetectable in the condensate of the operator, assistant, patient, or environment of any of these. This is great results. If our patients are all vaccinated, they have asymptomatic disease, we can wear N95s, use high volume evacuation, and do all of our aerosol generating procedures. I don't want you to misunderstand me. We are doing all aerosol generating procedures in my clinic, from implants to crown and bridge preps. I had one of my residents today did a remarkable case of seating 4 crowns and 2 partials in the same visit and having to do a buildup in the same time because of something that happened. And extraordinary resident did the whole thing in a very brief period of time. But we are using all of our aerosol generating procedures. We have not stopped. We did stop for a period of time, but once I had my HEPA filtration in place and my extra oral evacuation in place, I felt, and of course, the high-speed volume evacuation for my dental hygiene team, I was comfortable using all of our aerosol generating procedures once again. So I'm not opposed to that. I'm very much in favor of that because that's what we do. However, the study raised some flags for me. Their discussion, in summary, we find sufficient evidence to reject their null hypothesis that saliva is a potential source of disease transmission for aerosol generating procedures. They identify for the first time that irrigant used in dental equipment is the primary and major source of microorganisms during these aerosol generating dental procedures. They also demonstrate that high-volume intraoral evacuators are very effective in reducing salivary contamination of the surrounding environment and that pre-procedural mouth rinses consistently reduce salivary microbial bioloads. Again, very important for all of our patients. Within the limitations of the small sample size, they concluded that the risk for transmission of SARS-CoV-2 and other respiratory pathogens from aerosolized saliva in dental operatories is moderately low, not non-existent, not low, moderately low, and that current infection control practices are adequately robust to protect personnel and patients alike. And I agree with that. I agree with every statement that's in there. But I looked at this other study. And the study that I'm talking about now looked at the quantitative detection of viral load analysis of SARS-CoV-2 in infected patients. The viral load of respiratory samples was then compared on the average load of sputum was 17,500 plus or minus 7,000, was found to be significantly higher than in throat swabs, which was 2,500 plus or minus 2,000. And nasal swabs, which was 651 plus or minus another 500. So we know that sputum has the highest viral load, and it was 17,000. We know that throat swabs, which were in the throat area, 2,500 to plus or minus 2,000 copies per test, and nasal swabs, 651 plus or minus 500. Furthermore, viral loads in early and progressive stages were significantly higher than in the recovery stage. So almost 47,000 plus or minus almost 18,000 versus 1,250 plus or minus 1,000. And this is looking at sputum samples. The previous research that I just went over in detail, and I normally don't go over this much research in detail, but this really sort of hit a point. They looked at viral loads between 27 copies and 912 copies. So these folks that had SARS-CoV-2 present were asymptomatic and had very low viral loads. So the chances of detecting the viral particles would be much less dealing with this patient population as opposed to someone who actually had active disease and was seen. And I wanted to make that differentiation. So the question is, what are we doing different today? We've had some changes. We had this study that came out that shows that saliva is not a great source of the aerosol or the splatter that is generated on our shields and on our patients. We've had changes in how masking requirements are, how we should mask. I will say that I went into a local grocery store early last weekend on the Saturday. Most of the staff had on masks. Most of the patients, the clients, like myself, had on masks. There were more people without masks than normal, but it was okay. I went on a Sunday afternoon. I would say it was around 12:30. Half the staff no longer had on face masks, and over half the people in this particular grocery chain, did not have masks on. My concern is for people that are older, that are immunocompromised, that have not been vaccinated yet, and that we can't tell who's been vaccinated or not. So do I think when I'm outside, am I going to wear a mask? No. If I go to a Falcons-Buccaneers game at the Mercedes Dome and it's filled to full capacity and the roof is open, will I wear a mask? As much yelling as I'm going to do during that football game, other people are going to be yelling too and spitting stuff out, and so I'm going to have a mask on. I'm going to try to use as much common sense as possible. I know my neighbors have been vaccinated. I've been out to dinner with them. I've been to their house. They've been to my house. Will I, when I go around the block, when I'm exercising, and don't exercise enough. But when I'm exercising, will I have a mask on outside? The answer is no. Will I have a mask on the entire time I'm in my facility? Yes, unless I'm in my private office. That's my hospital rules. Has dentistry changed what we're doing when it comes to infection control procedures at this point in the pandemic? And the answer is no. Can you ask somebody for proof of vaccination? I guess you could. It's not really truly a HIPAA violation. But what does that mean if people can make false vaccine cards? We're sort of on an honor system right now. And whereas I know that in my state, it's closer to 34% or 30% that have been completely vaccinated, I will tell you that in that particular grocery chain that I was in, over 50% did not have on a mask. I don't know who to believe and who not to believe. Do I feel that I'm protected because I'm a relatively healthy person? I've had both my vaccines. Yes, I do. But I don't want to bring anything home where the other people that live in my home aren't as healthy as I am. And I take care of an immuno-incompetent patient population. So I think when we really look at this in the long run, we're at a remarkable turning point. We are not where we were a year ago. Our practices are back open. There are early indications that the pandemic has taken a serious impact on the oral health of those we serve throughout this country, whether they've had access in the past and have great insurance, or they're someone who needs to have low income or low resourced and don't have the kind of access that others have. But we do know that it's taken a toll on the oral health of Americans. In September, the American Dental Association survey found that more than half of the dentists who responded were seeing an increase in stress-related conditions amongst patients, including teeth grinding, cracked or chipped teeth, and symptoms of TMJ dysfunction like jaw pain. Also, more than a quarter of the dentists reported an increase in caries and periodontal disease, quite likely a result of people's changes in diets and hygiene. And now, as people get ready to go back into an office, I've been saying, and I know this sounds a little bit strange, but it's coming from me, I wear scrubs to work every day. The first time I went out to dinner, I honestly had to put on pants for the first time in almost a year. Luckily, the pants fit. I didn't have any COVID-related weight gain. But there's going to be a change that our patients have of having been home, working from home, who may now be switching to sometimes working at office, sometimes working at home, still maybe not having services set up to take care of their children, et cetera, et cetera. So will this stressful period continue? Yes. So we are now faced with a lot of unmet need, and our patients are going to want to come in now because the willingness of patients to see us is way up because we're a trusted part of the healthcare community. So my advice is we have services. We can't be healthy without oral health. Still follow all of the precautions that are in place until you hear from people who know more than I do. And that would be people from OSAP. That would be people who spend their entire careers on infection prevention, which I do, but there are other opinions out there. So I will be not only tuning in to see the Thrive Live, which will be on at the same time that this will show, but I'll also be attending the OSAP virtual conference, which starts from June 2nd to June 5th, because I will learn, and I hope that you will take the time to learn as well. As always, it's a pleasure to be here. I look forward to seeing your questions as they come in during the presentation. It's always a highlight to see that people are asking questions, and it's also informative on what it is that we, through these webinars, will cover. And so I look forward to seeing you again next month. Thank you for your time and attention, and as always, I'll turn it back to the wonderful Dr. Severance.
Thank you, Dr. Reznik, for your contribution and insight, and thank you all for joining us. If you have any questions or concerns or topics for future episodes, please email us at webinars@henryschein.com. And please don't forget to click the subscribe button below to be notified on all upcoming episodes. Remember, we are now going to a monthly schedule. And if you're finishing this webinar live on Friday and still want some more education and entertainment, head over to www.henryscheinevents.com/thrive-live, register for the 12 p.m. Eastern start time, and you'll be able to have lunch soon with Bravo's top chef fan favorite Fabio Viviani as he constructs the now infamous Scheinwich and more. As always, until next time, stay safe and stay informed.